a long time since we had our last rounds because most of our presenters are from GIM and everyone was working too hard during the last wave of the pandemic, so we had to put them on hold. But I'm delighted to see everybody again. Before I introduce our speaker, just the general rules. We like to see everyone's face at the beginning and then at the end to wave goodbye. If you have your camera on, we like to see pets and children, as long as Dr. MacDonald doesn't mind, but that's what we usually do. And it is being recorded, so if you have to leave, it'll be available on the GIM website on the Department of Medicine landing page. So without further ado, I'm really pleased to introduce our speaker for today, Dr. Michael MacDonald, who will be telling us about the new heart failure guidelines with practical tips on how and when to initiate quadruple therapy. For those of you who don't know him, I'm sure everyone does, but Dr. MacDonald is the Rogers Chair in Heart Failure and the medical director of the Ted Rogers Center for heart failure and the medical director for the Transplant Center at UHN. And he chairs the Canadian Cardiovascular Society guidelines on heart failure. So really the best person to be giving us an update on this. And I will turn it over to you. Thank you, Dr. MacDonald.
Thanks, Marta. That's terrific, and thanks for the invitation. And hope my impression of these rounds, not having attended before, is it's sort of a good forum for interaction and discussion. And I hope it's got a bit of an informal tone, because I think the best stuff comes when we're having some discussion about applicability of guidelines and therapies for heart failure patients. There are my disclosures that are relevant to the talk. And so really, I think there have been quite a few guideline update talks, including one at Grand Rounds a few months ago. And it's easy to find some of these talks in different meetings and updates. And it's going to focus less on the theory and the data that is already well known to the group, and hopefully more on some implementation and practical application stuff. And of course, you know, this is the real world, it's real medicine, and patients don't all belong in clinical trials, and we have to be able to think about, you know, how we use the art as well as the science of medicine, so to speak, for a lot of our heart failure patients. So that's really the objectives in broad terms. So again, for those who follow the Canadian Cardiovascular Guideline Program updates, whether it's in atrial fibrillation or the lipid guidelines, the heart failure guidelines are another key guideline component to their suite of guideline management. And the 2017 guideline update was a big document. That was a 90-page comprehensive update of all things heart failure. And then with additional data and, you know, stakeholder feedback, you kind of identify where you're going to focus your next guideline updates, and is there enough there, or is there enough to hang your hat on that we really need to change messaging and guidance. And in 2020, there was some new stuff out there on how to deal with functional mitral regurgitation, which is a debatable hot topic in subspecialty cardiology land. There's the emerging role of SGLT2 inhibitors, a little bit about heart failure with preserved ejection fraction and new therapies for that, and amyloidosis. But then in 2021, we sort of got together as a group and said, you know, there's really a lot in the space of heart failure with reduced ejection fraction. It's changing quickly. There were a number of negative trials that were somewhat disappointing, and then a number of positive trials that were somewhat surprising. We thought putting that into the equation and providing some perspective and guidance around that was probably worthwhile. So that's why the so-called treatment algorithm, we use the term algorithm a little bit cautiously because you never want to be too prescriptive about these things. But that's why the new treatment algorithm was born, so to speak, and most of you would be familiar. But just a quick few slides to review conceptually. If you look back in the 2017 guidelines, the name of the game, if you had low ejection fraction or HFrEF, heart failure with reduced ejection fraction, and anyone with an EF less than 40% is considered to have HFrEF. The name of the game was to get people on so-called triple therapy, an ACE inhibitor, a beta blocker, and a mineralocorticoid antagonist. And then if they still had a symptom burden, they were still at risk or vulnerable, then we could look at converting their ACE inhibitor, for example, to an ARNI, angiotensin receptor neprilysin inhibitor, and adding ivabradine, which is a sinus node slowing agent, because that seemed to be where the evidence was headed and what we knew to do within our comfort zone. And that was there are advantages and disadvantages to that stepwise approach. Once you have patients truly optimized, then look at more boutique therapies like devices, implantable defibrillators, resynchronization pacemakers. If they're really failing, think about your advanced heart failure therapies option and plugging them in with an advanced heart failure therapy clinic to think about things like mechanical support and transplant. And of course, that's really just a small slice of the overall denominator of heart failure patients out there. But some of the evidence that was encouraging or surprising, or that drove a change to our guidelines, came from some of these trials. This is not an exhaustive list, but it's the key examples of what drove a change in the guideline recommendations. So at the top here, the Pioneer HF study was a smallish trial. It was 800 and plus patients, which is small for a heart failure trial. And that really looked at the ARNI, sacubitril valsartan versus enalapril in hospitalized heart failure patients. And a good chunk of those patients, a third or so, had new onset heart failure. And that really looked at initially changes in natriuretic peptides, and in the follow-up studies had pretty good evidence that you start to see clinical events separate when you start the ARNI up front, even in a de novo heart failure setting, over and above the ACE inhibitor. So there's an advantage to starting more potent therapy during that hospitalization phase that translates later into improved clinical outcomes vis-a-vis reduced heart failure hospitalizations and mortality. And that benefit's realized surprisingly quickly. So there's a moderate level of evidence to drive a change in a guideline recommendation. A lot of the action in heart failure, and continues to be through 2022 and anticipated into next year, is going to be the space of SGLT2 inhibitors in heart failure, whether you have reduced or preserved ejection fraction. But really, for patients with an ejection fraction that's low, the twin trials of the DAPA-HF and EMPEROR reduced, which was a dapagliflozin study and empagliflozin study compared to placebo in chronic heart failure patients with or without diabetes. These were positive trials that showed a nearly identical magnitude in relative risk reduction of heart failure events, death or worsening heart failure. And so that was really gave rise to this idea that this is now foundational therapy in addition to our historic therapies. I'm not going to touch on the Victoria trial. This is more the domain of theory and emerging therapies. It's not really available to us yet. It's probably going to be really, really expensive and a so-called niche drug for vulnerable patients. So I'm happy to discuss vericiguat and its potential role. It did find its way into the guidelines, but that's not going to be the gangbuster that the other recommendations will be or already are. So it does, when you're trying to come up with guidance, where do you put some of these new evidence? Where do we put ARNIs in our treatment algorithm? Where do we put newer therapies like vericiguat? Where do we put older therapies, more importantly, like digoxin and vasodilators? There's no quicker way to start a fight at a cardiology conference than to say the word digoxin. Everybody's got an opinion and they're married to it. And then where do you put ICDs and defibrillators now? If you wait too long, you're putting patients at risk. If you do it too soon, you're putting patients at risk. So that's some of the philosophical, as much as anything, part of the discussion. And as many of you know, this is what if you've read the guidelines or are familiar with some of the summary documents, this is the central illustration, so to speak. And this really identifies that we want to get patients on 4 drugs where possible. So an ARNI preferred over an ACE inhibitor, plus a beta blocker, plus an MRA, plus an SGLT2 inhibitor, in no particular order, really. More on that in the slides that follow. And then consider whether there's an indication for additional medical therapy according to their phenotype or how they present and how their symptoms are doing. But whatever you do to get people on optimal medical therapy, you want to do it fairly quickly over the next few months. Ideally, by 6 months, patients will have had a good crack at this, because then we can reassess whether they have indications for device therapy or escalation of their care towards an advanced heart failure assessment. And then there are those patients, about a third, that do spectacularly well. And if you start out with low ejection fraction, about a third of patients now will have improvement in their ejection fraction, so that you no longer need to think about devices and advanced heart failure interventions, which is a growing proportion. And we're now starting to think of some patients, in fact, as having heart failure remission. Controversial topic, but it's a useful way to think about some patients. So key points when you look at the top level of a treatment plan or pathway is that 4 drugs are now considered foundational therapy, as I mentioned. And the text of the guidelines suggests that patients should be on at least one of these 4 categories unless there are contraindications. So an ARNI, a beta blocker, an MRA, or an SGLT2 inhibitor. And if you can't tolerate an ARNI, then an ACE inhibitor or ARB is probably reasonable. So this is the first polling question. There are a few of them peppered throughout, and some of them they're not intended to be tricky, and some of them are intended to provoke a bit of thought. But if you're reflecting on some of this and thinking of the patients that you might see in the wards or in your own clinics, are we supposed to titrate ACE inhibitor first, then a beta blocker, then an MRA, and then add on therapies from there? Or option B, start low doses of everything and titrate as tolerated, or C, start low doses of absolutely everything, including some of the niche therapies, and titrate? Or do you really just need to look at the scenario and make it up as you go along? So that's the polling question. See what you think. So Maura, I don't know if anyone's answered. Oh yeah, they have. Yeah, and I think that's sort of the mode, is that you kind of have to do it on the clinical scenario, which is sort of your least favorite form of advice, but it's absolutely true. You kind of have to look at the patient characteristics in front of you and then decide, is this someone that's going to do better when you add on medications one after another in sequence, like option A, and that is the historic way we've done things? Are we better off to save time and start multiple layers of medications at small doses and then go from there? And of course, the answer, I think, is it depends. And I totally agree that we probably shouldn't throw the entire kitchen sink all at once, but rather be rational in our prescribing patterns. And I put that polling question in because that's really what people talk about, and certainly it's an area for a lot of debate. When you look at key opinion leaders in the world and look at their strong opinions on things, that you get different bits of advice. So some people would propose, like these guys, McMurray and Packer, who are pretty well-known heart failure experts internationally, that maybe we should put everyone on an SGLT2 inhibitor and a beta blocker first, and then a couple weeks later put them on an ARNI, and then a couple of weeks after that finish them off with an MRA, and then we're done within a short period of time. But of course, that's I think most of us would view that as a pretty wild oversimplification of what we can do for most patients. Canadian authors have come up with this cluster scheme, and it's an interesting thought. Again, hard to know how actionable this is, but this group from Calgary advocated that let's start with 3 drugs at a time, and you can either choose an SGLT inhibitor or a diuretic, an ARNI or an MRA, and then a beta blocker or a sinus node slowing agent. And then every couple of weeks, see the patients and titrate one from each category as their physiology allows. And I think there's nothing wrong with this. It's just that, it's not going to be applicable to absolutely every patient. But it just, the 2 slides here kind of show you that this is where the headspace is. This is sort of the way we're trying to think about things in order to move the needle and improve the burden of optimal medical therapy. And again, it's really, this is a nice slide from a Canadian author that looks at least in clinical trial patient populations, what happens incrementally as you add good heart failure therapy. So, no patient should be untreated that should otherwise be treated. But as you add these heart failure therapies, you can realize a progressively better and better mortality benefit. And for patients that are candidates for 5 heart failure drugs, you can really see a very low mortality rate over the next year compared to an untreated patient. So it's a nice, simple graphic that makes a point. And I'll just show you an example from clinic. People only show their successes, but here's one. This is a lady I saw last year that was 66, and she was admitted in a pretty bad way when I was attending over at Mount Sinai Hospital with new onset heart failure. She had lymphoma and R-CHOP chemotherapy, so presumed mechanism would be an anthracycline-related cardiomyopathy or cardiotoxicity. And her ejection fraction was very depressed, about 20 to 25%. She was in gross pulmonary edema. She had functional mitral regurgitation, as half of these patients will. Coronary arteries were normal on cath, and we were able to send her home on a bit of a beta blocker dose, carvedilol, spironolactone, and some furosemide. And then I saw her virtually, like most patients we were seeing through the pandemic peaks. And she had reasonable symptom control on that regime. And her blood pressure, and not volume overloaded, blood pressure is 98 systolic, heart rate was 84, and her weight was nice and stable. In other words, she hadn't gained weight in the time since her discharge. So here's a menu of options to consider. There are other options that one could consider, but here are some of the ones to noodle on. So should we think about adding dapagliflozin, digoxin, and ramipril? Is it more attractive to start sacubitril valsartan, titrate or beta blocker, add a drug like ivabradine, or add an ACE inhibitor, ivabradine, and dapagliflozin? So this is where the nuance gets in a little bit. What do you think? We'll launch the poll here. Yeah, so again, this scatter of responses is kind of what I thought I'd see, and I think if I polled my colleagues that work in the heart function clinic with me, we'd see a similar pattern, and this really just depends on what you think the patient's going to tolerate and what your own priorities for the patient are. I don't view any of these as bad options, really. I think all are possible, and it's just a matter of what you think you can get away with. So I'll tell you what I did for her. I managed to get her over 6 months on some carvedilol at a much better dose. I did add ivabradine because she had a pretty profound elevated sinus rate. She was consistently in the 80s and occasionally 90s. Despite the carvedilol dose, I was able to sneak on a little bit of an ACE inhibitor, not very much, because again, limited by that relatively low blood pressure, tolerating the spironolactone, and added dapagliflozin. And because she had euvolemic, I actually stopped her diuretic and put her on just the dapagliflozin. And she's not back to normal. Her heart rate's better, blood pressure is low. She feels well. Her BNP is not normal, but it's still low. It's in the 220 to 230 range. We don't use NT-proBNP here. We use old-fashioned BNP. And certainly much better than her presentation. I thought I had these echoes playing, but her ejection fraction when she presented was 20 to 25%. And just on medical therapy, it had improved nicely. So this repeat echo shows an ejection fraction of about 50%, and that sort of fits with her clinical stability. So I was quite happy to see that, and maybe a bit surprised, because usually when you have anthracycline toxicity, you don't see such significant improvements in ejection fraction, but I think that's what we're seeing. So it's nice to see that some patients can do better than anticipated as we go. So next polling question is for your consideration, what is your opinion on this? Do you think optimization of GDMT or guideline directed medical therapy is really achievable in the real world when we apply this to non-clinical trial type patients? And your options are yes, no, or it depends, really. And so what do you think? Most people think it depends, and yeah, I think that's probably the best answer. I mean, it does depend, and it depends on what they bring to the table, and what kind of phenotype they've got and what their circumstances are. Certainly, when you look at registries in Europe and North America, at a population level, we know that there's a big potential gap, that patients are probably undertreated, or at least not treated in the proportions you would hope with good medical therapy. So in the U.S., looking at all comers in the what was called the CHAMP registries, about 3,000 or 4,000 patients. If you look at baseline and 12 months later, a snapshot at 2 points in time, there seems to be very little additional uptake of medical therapy. The increase in rates of prescription is a little bit underwhelming. And in fact, the baseline prescription rates for some of these therapies is a lot underwhelming. So it's probably not entirely that people in the United States don't know how to treat heart failure, but what are the barriers? Some of it's knowledge, but certainly there are other factors at play. And so it just highlights the need to do better wherever we can. And so it's a real challenge in the real world. I think in order to generate better outcomes, which is really having patients stay out of hospital and live better, and of course live longer, we need to optimize their therapies, and that's medication and device therapies where indicated in select patients, and this idea of health maintenance. So being able to track them between hospital visits, between clinic visits, and keep them well. So this health maintenance approach at a distance. And if we can achieve that, then maybe we can move towards better heart failure patient outcomes. But of course, when you reflect on some of the barriers, there is a knowledge translation barrier, and there's a lag in uptake of new knowledge. That's understandable, particularly when 50 to 60% of patients never see a specialist. They're managed exclusively by their family doctors, their primary care providers. There's social barriers, therapeutic inertia, which is a big one, patient reluctance, which is a big one, contraindications, of course, cost and pandemics get in the way, and they've really scuppered our best efforts in many cases here. So which of these things can we chip away at? This is pretty recent data from a subspecialty heart function clinic in Canada. This would be a sort of a partner clinic to us at the Peter Munk Center, similar type of patients, advanced heart failure, in Montreal Heart Institute. So Montreal data, they looked at 511 of their HFrEF patients followed in a clinic where their whole reason to exist is to titrate medications. And they looked at rates of prescription and physiology, and what they found is that they're doing pretty well. If you look at just the proportion of patients that should have been on a drug, so say beta blockers, 98 or 99% of patients who should have been on a beta blocker were on some beta blocker. And the rates of prescription for an ACE inhibitor or an ARNI or hydralazine nitrates for those who could not be on an ACE or an ARNI, mineralocorticoid prescriptions, they're doing pretty well. And you see that not all patients are optimized. So despite being on some dose of a beta blocker, for example, not everyone was on a good dose of a beta blocker. So why is that? What are the reasons for that? And this is a busy slide. I don't want to spend too much time on it, but I think the key takeaway, so if you look at I guess it's lime green box, those are the true undertreated patients. So what does that mean? So fewer than half the patients were at a maximally tolerated dose of a heart failure therapy in this subspecialty clinic that exists to get people on optimal medical therapy. And the reasons for that are variable. sometimes you run into physiologic limits. If the patient's heart rate is 50 beats a minute, you're not going to titrate the beta blocker any further. If their blood pressure is 90, you can't titrate an ACE inhibitor or an ARNI any further. I think that's what we mean by physiologic limits to titration, which is understandable. But there are still not insignificant numbers of patients that are undertreated. That is to say, they don't have a contraindication and no reason not to be on optimal therapy. So even in the best hands, so to speak, we have to be realistic about what is achievable. And in the real world, 100% is not ever going to be achievable. So maybe it makes sense to focus our efforts on closing the gap in those truly undertreated patients. So a couple of cases before we get into the discussion. I'm curious as to some thoughts around this, but these are fairly hot off the press. So 2 weeks ago, I was on service. This is one of the patients that that I admitted. It's a 55-year-old guy, 3 months history of shortness of breath, and he finally couldn't take it anymore, and he came into the emergency department. He was grossly volume overloaded. He was in atrial fibrillation, which was not known previously, and his echocardiogram showed an ejection fraction of 25%, and there's no significant valve disease there. He's got a history of HIV infection that was well treated. He's a high functioning guy, works as a lawyer with the government, i.e. has a drug plan, and probably drinks a little too much or was drinking too much. So he was diuresed for a few days to get him out of congestion, and he was cardioverted, and that was successful, and started on apixaban. His creatinine was normal, and his blood pressure was 135. So lots of blood pressure to work with. So prior to sending this guy home, what makes sense? Should we put him on an ACE inhibitor and a beta blocker and an MRA, or go straight to the ARNI and a beta blocker and an MRA? See what you think. Okay, yeah, I agree. I think this is a kind of patient that, so 83% of people thought option B, and this is the kind of patient that, say, 2 years ago or 3 years ago, this would not be the way what we were thinking. This not be done, really. And I think now, with a combination of evidence, some guidance, and of course experience, our comfort level is a little bit better with starting the ARNI in the inpatient setting. But I think you're still always weighing these decisions, right? So even though it's supported by evidence and guidelines, favoring the ARNI initiation, we know that it's a more potent drug and it's more efficacious, and we've got some evidence to support that. There's still an argument to starting with an ACE inhibitor in this guy. There's lots of experience with ACE inhibitors and lots of comfort. It's easy to titrate. It's not as easy to titrate the ARNI. It's a more of a sledgehammer. It can really drop blood pressure. And ACE inhibitors are cheap, and ARNIs are really not cheap. They're very, very expensive. So other considerations to make. So is this a reversible cardiomyopathy? Some of my colleagues would say, this guy, and you treat the atrial fibrillation, tell him to stop drinking, find out if he's got coronary disease, and treat what you can treat. His ejection fraction could improve quickly to within normal limits. Are you really going to commit him to a lifetime of an expensive therapy that he may not need? And that's an unanswerable question. That really comes down to, what do you think this guy in front of you is going to benefit most from? What are the patient's own values and preferences? And so that's the way a lot of the conversations go. And of course, can you ensure follow-up for monitoring him? So, so to me, I look at this guy with a really robust blood pressure, who's health literate, takes his HIV medications reliably, has a drug plan. I think there's probably more to gain than to lose by starting the ARNI. So what about an SGLT2 inhibitor prior to, is this the same patient? Let me just, yeah. What about an SGLT2 inhibitor prior to discharge? So this is a little more complex and less straightforward, perhaps. So One school of thought is yes, let's start the empagliflozin or dapagliflozin because it'll lead to less mortality and repeat hospitalization, and take the chance to start now while he's still an inpatient, or no, he's just had critical illness. We don't know what direction things are going to go. Let's leave it to the outpatient setting. So curious to see what your thoughts are here. Yeah, so interesting. So I think this reflects our current state of understanding and thinking. I think it reflects current practice. I'm actually surprised that even a third of people thought option A was going to be a reasonable thing to do. However, this is quickly changing, and if you follow the literature closely, again, this is into subspecialty argument territory, but there is an emerging bit of evidence about the use of SGLT2 inhibitors in patients hospitalized with heart failure. Probably the most powerful bits of evidence come from the MPulse trial. It was published this year. So again, hot off the press. And this looked at over 500 patients with a mix of heart failure. These are the low ejection fraction, the preserved ejection fraction, the diabetics, the non-diabetics coming in with hospitalization for heart failure. And they were prescribed either placebo or empagliflozin, 10 milligrams. Most of these patients were randomized within 3 days of presentation, which would be fairly typical for a stabilized heart failure patient. And they had this curious composite endpoint that looked at a win ratio, which kind of makes sense. I'm not an epidemiologist, but it makes sense when you read the methods that basically they look at two patients, and if one patient's readmitted to hospital, they lose, and the other patient isn't, they win. So you kind of go down in a hierarchical fashion between harder outcomes and softer outcomes, and you end up with favorable win ratios when you compare patients head to head on the outcomes, on the composite outcome, but on the individual components of time to death and quality of life and heart failure exacerbations. So in other words, if you start empagliflozin in hospital, it seems that you're going to be benefited in the HFrEF patient population with respect to heart failure recurrence and potentially mortality. So it's just interesting. This is not the be all and end all. It's not the final word on when to start this, but I think really encouragingly, there were no safety concerns. So the idea that everyone was going to fall apart with euglycemic ketoacidosis was not borne out. There were no events in the trial. So it was encouraging and reassuring that is provided you've got some good follow-up for these patients, I think that they would do well to start an SGLT2 inhibitor. And there are a lot of ongoing studies that are going to be a bit more definitive, but that's kind of where the current state of knowledge is heading. Practical guidance for initiating SGLT2 inhibitors. I think cardiologists have been a lot more reluctant and slower on the uptake with this. It's intimidating when you're not prescribing diabetic therapies. I think people are getting in the game and catching up to the endocrinologists and the internists of the world that have a lot more comfort with these medications. But I just show this slide because this is some of the knowledge translation efforts from the Canadian Heart Failure Society that is really trying to provide practical guidance for starting these medications. And of course, as you know, even when we're being hyper practical, these medications can be unwieldy. They're safe in the right population, but there are considerations, particularly in patients with brittle volume status. In other words, those prone to being dehydrated quickly, and patients that are brittle with their glycemic control and have insulin requirements, particularly if their insulin requirements are rapidly changing. So, and even amongst the endocrinologists that I bother with this question, I get sort of different answers about how to adjust hypoglycemics and insulin when I'm starting SGLT2 inhibitors. So I would say that, you know, from a personal reflection, I'm very comfortable in the non-diabetic patients or the diabetic patients that are not on insulin just starting the drugs and have not run into too many issues. But when they're a little more brittle, then I try to engage my diabetes colleagues closely. And then, of course, sick day management. We're trying to message to patients how to navigate some of their medications during times of illness where their renal function and blood pressure might be threatened. But again, I think we're trying to make life easier and more practical for implementing some of these newer therapies. So we go back to this case of the new admission from a couple weeks ago. He was discharged on sacubitril valsartan, or ARNI, at low dose, a starting dose of carvedilol, spironolactone, and apixaban. And the plan was to follow him up in the heart function clinic in 2 weeks and add either dapagliflozin or empagliflozin, and maybe titrate his carvedilol if his heart rate was elevated. So 15 minutes before I came to my office here, I saw this guy in clinic. He's doing really well. His blood pressure is 110. His neck veins are down. We stopped, I should mention he's on 20 milligrams of Lasix. I stopped his Lasix and started him on DAPA 10 milligrams, and we'll see how he goes. And I think, and his heart rate's 60 beats a minute now. It's amazing once you're out of heart failure, how your heart rate just comes down nicely. So not a lot left to do, other than we'll see him in a couple weeks and probably nudge up his sacubitril valsartan if his blood pressure will tolerate. And then he's pretty good. Then we just sort of wait and see how his ejection fraction settles out and whether we need to do anything else. And we're going to send him for an angiogram because I still don't know what his coronaries look like. Okay, second case before we wrap up for some discussion. This is a 64-year-old patient I admitted 2 weeks ago on service with a bone marrow transplant back in November. She was really sick. She had pulmonary edema, hypotension with a blood pressure of 85, and acute kidney injury, really bumped her creatinine. EF was shockingly bad. Presumably, it's related to cardiotoxicity from previous chemotherapy exposure. She's got a history of hypertension. Otherwise, that was well controlled. She's again, she has good health literacy. She's a former nurse. She was on milrinone for a few days, and then everything just sort of got better. Sometimes you can't easily wean the milrinone, but sometimes you can. Her renal function improved, not to normal, but to a much better state of affairs. And then the question for her is, what do we initiate before sending her home? ARNI, beta blocker, MRA, SGLT2 inhibitor, digoxin, and or hydralazine. She's a little sicker, a little more complex. See what you think. Yeah, so it's very attractive to get her on the right, pack of guideline therapies rather than second best therapy. The question is she going to tolerate it? And so, favoring guideline directed medical therapy, it's better. Her creatinine's trending in the right direction. And alternatively, there are fewer adverse hemodynamic effects. If we think about digoxin and a little bit of low dose vasodilator therapy, there's less concern because she's recently had some kidney injury, and maybe we just need to bridge her to the outpatient setting. So she'll need close follow-up no matter what. And certainly if her renal function is stable, she'll be a good candidate for at least an ACE inhibitor and an MRA if her blood pressure would tolerate. I think her blood pressure would need to be better before starting an ARNI. So I sent her home on spironolactone, which I think is usually well tolerated, digoxin, a little tiny bit of carvedilol, which I was happy to see her tolerate, and low dose furosemide. I enrolled her in our remote monitoring program so I can follow her vital signs every day. As many of you know, we call that MEDLEY in our heart function program. And every day I see her blood pressure register 85 to 90, but she feels pretty well. Her heart rate's still way too fast. So my own plan for her is to see her next week and probably stop her furosemide and add an SGLT2 inhibitor if she's euvolemic. I'm not sure she'll yet be able to titrate to tolerate the ACE inhibitor. We'll have to see. But she's going to be a good candidate for ivabradine to slow her sinus rate down without adversely impacting her blood pressure. So other challenges in the real world, this is sort of final thoughts, and then look forward to the discussion. The real world, we deal with patients that are advanced age, cognitively impaired, language barrier, mobility barrier, poor caregiver support, nursing home or long-term care setting, comorbidities and polypharmacy. Of course, that's going to limit what we can do. So what can we do to help some of these patients? And I think, we can view it as a challenge, or we can view it as a challenge and maybe some opportunity. I mean, certainly take the occasion of their hospitalization to optimize them, and make sure we have good communication with their caregivers and support where we can. And then a lot of these patients just can't get to clinic easily for the reasons above. And maybe, we augment our virtual care, and we're still learning how to do this well and select patients well for remote monitoring and virtual care, and focus really on the true under-treatment gaps. We're not going to get everybody that fits this profile on a good dose of an ARNI. That's just not, that's sort of magical thinking. So in summary, I think we know the standard of care has changed, especially the pharmacologic standard of care. We have to be rational prescribing therapies and acknowledge our limitations and the patient limitations and account for their clinical phenotypes. I think real world optimization is feasible. We probably don't do a good enough job at this at a population level, but I think there are also real physiologic and patient limitations. And unfortunately, we're still in a state where the most vulnerable high-risk patients are the least likely to receive optimal care. Again, reflecting on the previous slide. And so I think we need to use the hospitalizations as an opportunity to optimize their treatment, and then hopefully leverage some emerging technologies for remote and virtual care. So I'll end there, and maybe there'll be some discussion. I haven't checked the chat functions, so that we can review some of that too. But any questions off the top?
So thanks, that was really fantastic. Thank you. So there are quite a few questions and comments in the chat. So maybe I'll just go back to the start of those and go through some of those, if that's okay.
Please, yeah.
So the first question is from Danny Panisco, and it goes back to when you were discussing which medications to start first. And his comment was, shouldn't we prioritize the class with the greatest mortality benefit first in our introduction?
Yeah, and I think that's great. And it's hard to know truly what medications have the greatest mortality benefit, because the trials follow patients for varying periods of time. But if you look at the relative risk reduction in a typical 3-year follow-up study for a HFrEF patient, spironolactone and eplerenone have about a 25% reduction in mortality in the patients enrolled in that trial. ACE inhibitors and ARNI have about a 20 to 25% mortality reduction. Beta blockers, 25 to 30% mortality relative reduction. So the challenge, though, and dapagliflozin, empagliflozin, 25%, mortality reduction in aggregate. So the challenge is that when these studies are done, the newer medications are done in patients already treated with the older medications. So you're demonstrating a benefit over and above what was already pretty decent therapy in a well-treated clinical trial population. So it really is hard to tease out, like, what is the most potent therapy? Is it the newest one that showed, winning strategy despite patients being well-treated in contemporary trials? It's hard to know. And then, of course, the newest treatments are also the most expensive. So, that's not a trivial piece of it. So tough one.
Thanks. Do you want to stop sharing your slides
Yeah.
now? We can see everybody.
All right. Yeah.
Thank you. So the next question actually is from Umber Najib, asking about the price difference between, I'm going back to price difference between ARNIs, SGLT2 inhibitors as compared to ACE or ARB for patients under 65 who don't have a drug plan.
Yeah, so I think ARNIs in particular are really expensive. I think they're about $180 a month. So that's not feasible for patients without a drug plan in most circumstances. So that can be a non-starter right there. The SGLT2 inhibitors are also expensive. I can't recall what they cost a month, but I want to say they're about $2 or $3 a day or something like that. So again, non-trivial cost for a lot of patients. But the ARNIs are certainly the biggest driver of costs and for a lot of patients. And then ACE inhibitors, MRAs, they're pennies. Beta blockers are really cheap.
Okay, thanks. And then Barry Goldlist has made the comment, in some studies, 50% of patients in heart failure clinics have some degree of cognitive impairment. Does that affect treatment decisions?
Yeah, I think it does. And I think, in cardiology land, we're not as good and attentive at this as we maybe ought to be, because we don't know the implications on cognition. Of course, there's theoretical animal models that show cognitive impairment when you treat them with some classes of heart failure medications like the ARNIs. But you want to make sure that medication is the same principles that you'd employ to simplify any complex medication regime. Once a day medications are better than twice a day, blister packs, caregiver oversight. But I don't know that cognitive impairment per se, all other things being equal, should change your approach to trying to optimize the heart function.
Okay, thanks. And then there's some discussion about the timing of SGLT2 inhibitors and when they were started in the trials. Pete Wu says he thought it was an average 3 days into hospital admission. And then some discussion that at Sunnybrook, they can't be used in hospital, so it's a challenge.
I wasn't sure if that was still the case, but sounds like it might be. Yeah.
And then lots of comments about the GIM population and no follow-up, no drug coverage, making it really complicated to treat patients. Okay.
Yeah.
Pete Wu, you have your hand up.
Thanks, Mike, for the talk. That was great. I had a question. If you're does your approach to titrating heart failure therapies change, factoring in ethnic variations in drug response, specifically beta blocker response in patients who are Black and isosorbide dinitrate hydralazine? Should we still titrate as usual, or is there do you sub in ivabradine for the beta blocker and ISD and hydralazine for the ARNI or MR or like that? I don't know if that what we should be doing in those situations.
Yeah, you're right. I think that's very nuanced and true. And so you sort of have to individualize things. I think for the most part, we don't know for sure, along ethnic lines, for example, racial lines, what drugs work best in every situation. So we generally apply this data to broader populations of patients. The exception is as you identified, patients, Black Canadians, for example. We think that there's a pretty good signal that that response to a combination of vasodilators, for example, it tends to be very favorable. So I think when you're seeing these patients, you do what you would do for everybody, but then have a low threshold to pivot or add on vasodilator therapies for Black patients. And I think we're just not sophisticated in our knowledge enough to know how to personalize therapy much better beyond that right now. But I think that's the whole stretch goal, is identifying, rather than a meal of 5 or 6 pills for everybody, which 2 or 3 work best for which patients. And we're just not good enough to know that yet.
Thanks. And now we have our local king of SGLT2 inhibitor therapy, Mike Freilich.
Hey, thanks, Moira. Mike, that was a great talk. I just wanted to clarify, for the ARNI initiation in hospital, that Pioneer HF trial, wasn't the primary outcome just a change in BNP? So I'm surprised all the enthusiasm of starting it in hospital, or is there other evidence as well?
Yeah, yes and yes. So yeah, that study was just looking at a change in natriuretic peptides over 8 weeks. And so it's pretty hard to jump up and down and say, this is really what everyone needs to do. But that being said, it was a striking change in natriuretic peptide levels, which for in every in every study correlate nicely or associate nicely with heart failure outcomes. There was a transition HF study that looked at a similar thing. Are you better to wait to clinic or start in hospital? That again showed good safety and tolerability of starting the ARNI in hospital rather than waiting to the outpatient setting. And then the extension phase of the Pioneer study looked at another few months of data, and that's where you started to see separation in the clinical outcomes. So by about 12 weeks, you started to see meaningful reductions in recurrent heart failure hospitalizations in particular. So it's a moderate level of evidence as we graded it, but it's, and to summarize, we've got good safety and a signal towards pretty good efficacy over and above the ACE inhibitors. So the enthusiasm is there, but tempered with all the caveats that you've highlighted, and then all the other real world stuff like cost.
Thanks. Joel Ray.
Michael MacDonald, it's great to know you're chairing the guidelines committee because you are great at explaining these management approaches. Can you comment on furosemide dose reduction and elimination, which you've only softly alluded to?
Yeah, it's a great question. So, people are so reluctant to make changes. So if you've got someone doing well on a bit of Lasix and then they show up to clinic and look good, there's a tendency to say, well, let's get them off their Lasix. And there's also a tendency, a tension in your head to say, well, let's keep them on their Lasix because it's working well. And sometimes you don't know what the right approach is. And there's a little bit of, I believe it's RCT data on this. And it turns out that if you stop furosemide, nothing bad happens, assuming they're not volume overloaded. So we've got a little bit of evidence, and I can't remember the study name. It's fairly recent, that suggests that, yeah, if you stop furosemide and all the other good stuff is on board, then there's reason to think that patients will remain stable and have one less medication to take.
So, and my allusion to that is that there's actually no level 1 evidence for furosemide, which isn't to say we wouldn't use it, we would. But once you've crutched the person out of acute heart failure, it would seem logical to eliminate an evidence-free agent, and perhaps the guidelines need to get on that a little more aggressively because they don't have the level of evidence as they do with the other agents.
Yeah, it probably needs a bit of an exclamation point because everything you said is true, especially in the era now of SGLT2 inhibitors. If you have someone who's euvolemic and you want to start a empagliflozin, for example, or dapagliflozin, it doesn't make sense to keep them on their diuretic, their loop diuretic, in addition to the SGLT2 inhibitors, unless they've got recurrent problematic volume overload. So totally agree.
Great, thanks. So we're almost out of time. There's just a quick question from Barry. Do we have enough cardiologists to handle the heart failure referrals? I'm sure we don't.
No. Yeah. No. Yeah, and it's a huge system thing, and people talk about this all the time, and you're trying to design systems of care that are just in time and good enough and prevent. And that's where that little comment I made about health maintenance is so important, because if we can avoid those intercurrent decompensations and having the wheels totally fall off, then maybe we can do this to scale. And so the remote monitoring experience has been pretty favorable, where we can have a nurse clinician manage up to 400 patients, and you only get notified when they're in crisis or when there's questions about their management. So it allows you to do things to scale, and like everything, it's going to come down to selecting patients appropriately. It's hard to do right now.
Great. Well, thank you so much. That was extraordinarily useful, practical, just what we needed to hear. So thank you very much. Before people leave, don't forget to do the evaluation. Tina put the link in the chat. These rounds are accredited by the Royal College for 1 hour of Section 1 credits. And next month we have a packed agenda with 2 speakers, John Mong on addictions medicine and Daminda Wijasundara giving us a perioperative medicine update. So hope to see you all then. Thanks again, Michael, and thanks everyone for coming.
Thanks so much.
Bye.